March 5th to 7th, 2026. The place is Canterbury, Kent, in southeast of England. There's a social gathering going on. Young people and teenagers are attending that. They are enjoying the music, they are having fun. And a few days afterwards, some of these people who attended this gathering, they start becoming ill. Some of them, they are hospitalized because they have got a very quick downhill course, and they present with signs and symptoms of what we call as meningitis. When the doctors, they investigated, they found out that some of them were actually suffering from a deadly strain of a bacteria known as Neisseria Meningitidis, and two of them, they unfortunately died. That led to a big public scare as the news came out, to the extent that now people were rushing to the hospital to get tested because they were scared that they might be carrying this infection. So, what is this bacteria called Neisseria meningitidis? What is meningococcemia? And what is meningococcal meningitis? We will be discussing this right all on my channel. So, stay tuned. Hello, my friends, and let's talk about pediatric meningococcemia and meningococcal meningitis. So, as I discussed earlier, that there has recently been an outbreak of meningococcemia and meningococcal meningitis in the southeast of England, caused by some strains of the Neisseria meningitidis, especially the Neisseria meningitidis serotype B. That has created a lot of scare in the public. So I thought this is the best time to talk about what is meningococcemia and the associated conditions, associated with this bacteria like meningococcal meningitis. Let's discuss in detail. So to begin with, let me tell you that Neisseria meningitidis is basically a bacteria. It's a gram-negative diplococci. So it means that it stains negative on the gram staining, and it usually is in clusters of two. That's why it's known as diplococci. Diplo means like two. Cocci means that they are rounded in shape. As you can see in this diagram, there are two bacteria which are clumped together in a cluster of two. That's why it's known as diplococci. And as I told you earlier, that it stains negative on the gram stain. Now, it is known to have at least 12 strains, but of those 12 strains, only 6 of them, they are known to cause major disease in the humans, and that major disease is known as invasive meningococcal disease. Invasive meningococcal disease means that this bacteria basically invades the body. It goes into the bloodstream. It can infect different organisms and then cause a massive shutdown of those systems where it invades. But it can also remain in your upper GIT flora, like in the nose and mouth, as a normal commensal. So out of those 12 known serotypes, the ones that are known to cause invasive meningococcal disease are your ABCWXY. So you can simply remember it by the first 3 words of the alphabet, the ABC, and then the last few letters, that is W, X, and Y. Of them, again, if we talk about the global distribution, especially in Europe and UK, the leading strains which can cause this invasive meningococcal disease from time to time, they are serogroup B, or the serotype B. Serotype A and X are mostly occurring in the African meningitis or meningococcemia belt, but by and large, by routine immunization, most of the meningococci serotype A has been eradicated, and now we are seeing most of the X strain as far as Africa is concerned. As far as the serotypes W and Y are concerned, they are present all over the world, especially in the United States, where some of the hypervirulent W, that is serotype W, can cause outbreaks from time to time. But as far as the Europe and the UK is concerned, most of the time when it becomes a problem, that is the serotype B, because serotype B vaccination was only started in UK in 2015. So all kids who are at the moment less than 11 years of age, they are already been immunized. They get 2 vaccines at 8 and 12 weeks effectively. So that gives a good immunity. The immunity, as I will talk later, is around like 83% immunity, 17% still be susceptible to invasive meningococcal disease. The other thing is that before that, the vaccination that was offered in the UK, that was the combined the polyconjugate vaccine, which is known as the ACWX vaccine, and that ACWY vaccine, sorry, and that has been offered to teenagers. But as I told you, mostly in the European belt, it's the serotype B that causes outbreaks from time to time. Moving on, talking about this recent outbreak which happened in the March of 2026. Basically, this was a social gathering in the southeast of England where the young people they attended, and nobody knew that somebody who was carrying some of the deadly strains of this serotype B, somehow it spread by close contacts among the young people. This event happened between 5th and 7th March. So those people who attended, some of them, they became ill after that. And that illness progressed till they were hospitalized, and they presented with signs and symptoms of meningitis. As they were investigated, the pathologists, they found that few of them were actually their culture came up positive, or their tests they came positive for this serotype B of meningococci. And unfortunately, two of them died. Some of them are quite serious, and then a few other cases happened here and there. That has created a lot of public scare. So the thing is that scare on being one side, the outbreaks do occur from time to time, so it's not very unusual, because this basically uh, spreads with very close contact among the young people. So the target populations which are usually targeted for prevention are the young adults and their families, because adolescents are mostly the carrier of this disease, and they usually carry it in their nasopharynx. So the organism, if it is thriving, it's usually thriving in their nose and mouth. So it's important to recognize the clinical deterioration which can occur quite quickly in these conditions, and then to empirical antibiotic treatments remain the mainstay of treatment that can actually reduce the mortality associated with this condition. And obviously that has to be tied with massive mass immunization in case where the outbreaks they happen. So how does meningococci they present, especially in children? Now, the early signs, that is in the first to 6 hours, because all this has got a few days of incubation time period, usually majority of these kids would present with fever, except the neonates, which obviously because of their poor thermoregulating system, they can present with hypothermia. The fever or hypothermia, both fever mostly in older children, hypothermia in neonates, that can be one of the early signs. But fever or hypothermia can occur in so many other conditions as well, like most of the viral infections, they can present with the very same thing. And obviously lethargy and irritability, which is usually very non-specific, can occur in the young kids with poor feeding. But one important thing that occurs with this thing are the pains, the body, especially the upper back, the lower back, the neck, and the limbs, which have got severe pain. Like that is usually out of proportion to the amount of fever that they are having. So severe body aches can be one of the earliest signs that can point that there might be a possibility of a meningococcal infection. So usually in the very beginning, there are non-specific signs that might present as like cough and cold or flu-like symptoms. But the only thing is that very quickly it progresses. Like while of the other illnesses, viral illnesses would stay on, even if they are staying for 5 to 7 days, they stay more or less at the same level, while this condition rapidly deteriorates. With 20, like for 24 to 48 hours, the child goes like this, crashing. So some of the indicators, the red flag warning signs, is any child who develops these non-specific symptoms, but there is very quick progression from bad to worse, then you should always think that there might be an underlying meningococcal, or sometimes not only meningococcal, other invasive infections can also present the same way. So it's very important to see the trajectory of the illness. Obviously, as I told you, that the major dilemma or the confusion is that the early signs and symptoms are very, very non-specific. Some people talk about the non-blanching rashes and things like that. I will come to that in a moment. But those rashes can present in certain forms of invasive meningococcal disease, like meningococcemia, but they might not be present in other forms of invasive meningococcal disease. So we should not only rely on the presence or absence of rash. Remember, if a child very quickly goes from bad to worse, irrespective of how he's presenting, like it looks viral or anything else, you should think of invasive disease it could be any invasive disease, but like, when we have to cover them up, we have to cover for meningococcemia as well. So that's the most important message that I want to deliver here. Now, a late clinical presentation, again, it depends on whether this meningococci is causing a septicemia-like condition in which the bacteria has invaded the body. It's like freely swimming in the blood and it's going to every organ. So we call it as meningococcemia. And meningococcemia can usually presents as a rapid deterioration with multi-organ failure. Why multi-organ failure? Because this organism is freely flowing in the blood and the blood is going everywhere. So you can have renal shutdown, you can have acute lung injury, you can have acute liver failure and heart failure as well. You can have adrenal hemorrhages in that, you can have brain hemorrhages in that. So that is like a very wide shutdown of the body caused by invasiveness of this bacteria, which is going in every nook and corner of the body. The other presentation is what we call as meningococcal meningitis, where the bacteria just goes through the blood-brain barrier and inflames the coverings of the brain and the spinal cord. They become very much inflamed and they become swollen, and that usually causes next, because these, the covering of the brain, they're not only on the brain, they are over all of the spinal cord, and spinal cord pass through the neck and the back. So there would be a lot of soreness and stiffness in the neck and back. So they will be like complaining of severe backache to the extent that they might be arching. The neck is so stiff in certain cases that's very difficult for them even to move their neck. So one of the tests that we usually do is looking for neck stiffness is that we ask a child to touch his or her chin to the chest, and if they feel difficulty in doing that, we call, okay, the neck stiffness is present. And if neck stiffness is present, it means there is a meningeal inflammation. Now, some might argue that it can be caused by viruses as well. Viral meningitis is not uncommon. I mean, enteroviruses can cause that, but again, that is a self-limiting condition. The thing that we would be worrying about is the meningococcal meningitis. Obviously, for viruses, we don't have any treatment, but for bacteria, we do have treatment. We do have good antibiotics. So it's better to like cover them with antibiotics, empirical antibiotics, till we get the actual results, whether there is actually meningococcal meningitis, whether the bacteria has been isolated or not. So in the meningitic form of invasive meningococcal disease, there would be classic symptomatology of meningitis, like they would be having fever, they would have got vomiting, they might have altered mental status, sometimes they might have photophobia, but most of the time it's the neck stiffness and back pain due to which they have got neck stiffness, and the particular signs which we call as Kernighan-Brunson sign might be positive. In very young infants, there might be bulging fontanelle, a lot of irritability. They don't present with neck stiffness. There would be fever. The child would be very much lethargic, not responding to social cues. There might be bulging fontanelle, vomiting, and non-specific fixture, but the child looks very, very unwell. And as I told you, in the journal invasiveness, the journal invasive disease in which the whole body is affected, basically, which we call as meningococcal septicemia, it can very quickly lead to profound shock. So the blood pressure can go down, the child can have adrenal hemorrhages. They usually present with these rashes, but those rashes quickly spread, like not only petechial rashes, that can turn into puerperic rashes. Sometimes uh, uh, a condition in which all the coagulative factors, they are consumed, and there are very large patches of bleeding beneath the skin, internal hemorrhages. We call it purpura fulminans. It's a skin necrosis, limb ischemia with multi-organ failure, and that is almost like a very, very high mortality. Again, as I said, do not rely completely on the rashes, okay, because non-blanching rashes, though it can, as I said, like it can present in this condition where it is usually spreading and the child is very unwell. But the non-blanching rashes can present in many other conditions as well. For example, if a child is vomiting and coughing forcefully, you might see non-blanching rashes in the upper torso. More common than meningococcemia or enteroviral infections. Enteroviral infections also give fever with like a generalized petechial rash. But as I told you, with these rashes, if these rashes, the child is unwell and the rash is spreading, then you should always think of meningococcal meningitis or meningococcemia in general, and you should treat it till you are either sure that it was meningococcemia, meningococcal, or you have ruled out. Diagnostic steps involved in diagnosing this condition. Again, like diagnosis is based on laboratory investigations and sometimes taking the fluid from specific areas like the cerebrospinal fluid examination through the lumbar puncture. But remember, the investigation should not delay the treatment. We always say that if you are suspecting a child who's febrile, who's going downhill, what you should do, you should immediately get IV access. You should take bloods for obviously your full blood count. You check for inflammatory markers, you check for liver function and the renal function. You should take at least a few bottles for blood cultures as well. Okay, you can take it from different sites as well, but let's say if it's not like possible, just take it from one site. And if you're suspecting the meningococcal meningitis, meningococcemia, you can take some blood for meningococcal PCR, because culture is going to take some days. It's better, PCR is more quicker. So you can take the purple top bottle, that is the EDTA bottle, and you can fill it up for the meningococcal PCR. So these are the lab investigations. As you are drawing blood, at the same time, you should give them broad spectrum antibiotics. And specifically, if the meningococcemia is on your mind, obviously we sometimes when we are giving the blind therapy, we cover from gram positives, because some gram positive organisms can also cause invasive diseases like the invasive streptococcal disease, things like that. But we also cover from the gram negative organisms. And if you are thinking of the meningococci, then you should be giving ceftriaxone. That is still the standard uh, antibiotic for treating meningitis. So usually in children, 80 to 100 milligram per kg, or for older, you can go up to a maximum of 2 gram stat dose of IV ceftriaxone. In certain conditions, like if you are suspecting meningococcal meningitis, in which there are CNS signs and symptomatology along with like neck stiffness and things like that, then it's better to do a lumbar puncture as well. But before we do the lumbar puncture, again, the lumbar puncture should not delay the treatment, number one. Number two, before you are doing the lumbar puncture, especially in older children, you have to rule out increased intracranial pressure. And for that, we do a CT scan just to make sure that there's no increased intracranial pressure. And if that is reported to be showing no increase in intracranial pressure, then we go for the lumbar puncture, so in which the cerebrospinal fluid is taken, and then it can be done with the gram staining. The meningococcal PCR can also be done on the CSF, and at the same time, the CSF can be cultured to see if it grows gram negative diplococci consistent with meningococci. And it can also tell you whether this is a bacterial meningitis or whether that's a viral meningitis, or in rare cases, a tuberculous meningitis. So to sum it up, you need to do lab investigations, and depending on the clinical picture, sometimes a lumbar puncture, but that should not delay the treatment. You should always give empirical antibiotics while you have taken the blood. Then as far as the drug management is concerned, obviously when we are not sure in the beginning, we always cover for all the major organisms, whether gram positive or gram negative. So to cover the gram negative, especially the diplococci, in this particular case, the meningococci, we can give ceftriaxone. So in very younger kids, like in the neonates, we usually go for cefotaxime, which has got more or less similar efficacy. But for older children, ceftriaxone is the drug of choice, intravenous ceftriaxone. Sometimes if we are thinking that there might be invasive pneumococcal disease, then we can add vancomycin in that particular case, because in the beginning we don't know. Broad spectrum antibiotics in very young infants, that are the neonates and those less than 3 months, we can give ampicillin for cefotaxime, because that covers most of the organisms that can cause sepsis in that age group. If the pre-hospital treatment, where the paramedics or those people who come across these kids, okay, so it's better to give them intramuscular benzyl penicillin, because benzyl penicillin can also is quite effective against that is Neisseria Meningococcal. While transporting them to the hospital, a child is very unwell and they are suspecting, they can give intramuscular dose of benzyl penicillin. Corticosteroids, I mean, this is questionable. Corticosteroids are only given if the invasive meningococcal disease is presenting with like a picture of meningococcal meningitis. Why we give it only in meningococcal meningitis? Because when the meninges are inflamed, there are adhesions between them, and that adhesion can cause obstruction to the flow of CSF, leading to sort of increased pressure. Sometimes it can also lead to damage to the neurons, causing deafness later on. So that's why where there is a picture of meningitis and the doctor thinks that the meninges are inflamed, then Not only the antibiotics are given, but the corticosteroids like IV dexamethasone is also given along with the antibiotics to reduce the chances of adhesions in the membranes of the brain, and also to reduce the chances of deafness, which can present later on. Then as far as the contact management is concerned, so those people who are the household contacts of a diagnosed or a probable case, because this infection is spread by close contact. I mean, this is not an airborne infection. This is a droplet-based infection, so it always occurs with close contact, like, for example, coming in body-to-body contact with one another. So those people who are very close contacts of these, like the partners, the children, or the other household which are living in the same house or in the same college and the same dome, they have to be given prophylaxis. So for prophylaxis, either ciprofloxacin, single dose of ciprofloxacin, or a single dose of rifampicin is used for eradication of the like those people who might have been exposed and they might be carrying that in their nasopharynx. And ideally, it should be given within the 24 hours of exposure, but it can work up to 72 hours. These days, in certain parts of the world, there have been reports of resistance against ciprofloxacin. So in that particular case, azithromycin can also be given as a stat dose. But here in UK, we are still using ciprofloxacin as the major medication for close contacts of the people. And alternatively, they are using rifampicin. But in those areas where there has been reported ciprofloxacin resistance, then azithromycin is the choice. Moving on to the vaccines. Vaccines have got a role. I mean, traditionally, for a long time, the teenagers have been given what we call the conjugate vaccine. That was basically the meningitis ACWY vaccine, which is given to like secondary school children, usually given in year 9. Now, they actually give you some seroprotection against the A, the C, and the W and the Y strain, but they do not give any protection against the B serotypes. So from 2015, this meningococcal B vaccines that comes under the name of Bexsero, that has been incorporated in the UK immunization schedule. The other countries have got their own immunization schedule, so they might have also included that. That is particularly specific to meningitis B strains. It is given at 8 weeks and 12 weeks. And that gives you protection against the B strains, which are more common in Europe. There has been work on the new pentavalent vaccine, which comes under the name of Penbria or Penmenvy, and that combines the ACWY with meningitis B vaccine. So you've got a pentavalent vaccine, which contains like antibodies against A, B, C, W, and Y. It has been FDA approved and licensed in the United States for ages 10 to 25. And the thing is that you don't have to give meningitis B in the early childhood and then followed by these vaccines in the late adolescent age. Like the one vaccine covers all of these strains of meningococci. So as far as the vaccine efficacy and public health outlook of the vaccines is concerned, there is 83% like vaccine efficacy of the Men-B vaccine. So Men-B, if it, like, let's say if you give it to 100 kids, okay, 83% of them would develop effective antibodies or enough number of antibodies that give them protection in case if they get exposed. 17% would still have like susceptibility to like get the infection, but still it prevents against the invasive forms of meningococcal. So even if they develop, that might be a more milder illness. But at the same time, this 83% efficacy translates into 75% reduction in the disease burden. So like, let's say the number of cases that are happening, 75% of them would be reduced by vaccinating children with this vaccine. And they say that there is some degree of cross protection as well with Bexsero, like that is a meningitis B vaccine, that it gives some protection against the hypervirulent serogroup W strains as well. And the WHO global goal is to defeat meningitis by the year 2030 by eliminating bacterial meningitis epidemics and reduce vaccine preventable cases by 50%, and they cut the mortality by 70% because mortality is very high in invasive meningococcal disease. And how do they plan to do this? Is through enhanced vaccination of the communities, developing rapid diagnostic tests, and standardizing the clinical care of these cases. So this was all about meningococcemia and meningococcal meningitis caused by this organism known as Neisseria Meningitidis, which is nowadays creating public scare. It's there everywhere on the news. Remember, this is not something new. Epidemics have been occurring from time to time. All it needs is good knowledge, good skills to diagnose well in time. And if diagnosed and treated well in time, the mortality is not high. It's usually in the end stage when the thing has been missed or you are not suspecting it, and the multi-organ failure has set in when the mortality rises basically. So if treated early, that actually prevents the mortality associated with the illness. Hope you have learned something new. Share this with your friends. If you've got any comments, put it down in this comment section below, and have a very good day. Stay safe. Bye bye.